Hello, hello, and welcome to Wound Care Wednesdays, guys. So it's just going to run like last week. If you have any questions, just write them in the chat, and I will do my best to answer any questions you may have. Feel free to say hey in the chat so I know you're here. Hello, if you have any questions about wound care, feel free to drop them in the chat and I will answer any questions that you may have. If you have any wound care questions, please feel free to put them in the chat and I will answer those. If you have any wound care questions, please just feel free to throw them in the chat and I will answer those for you. if you have any questions whatsoever about wound care, please feel free to put it in the chat and I will answer those questions for you. If you have any wound care questions or a topic that you would like me to discuss, please feel free to put it in the chat and we can talk about that. If you have any questions about wound care that you would like me to discuss or a certain topic, feel free to ask any questions. If you have any questions whatsoever about wound care or topics that you would like me to discuss, please feel free to just put them in the chat. Okay, so if you're a diabetic and you got a roofing nail stuck in your shoe, did it break your skin? I'm assuming that it did break your skin. You want to make sure that that's cleaned out very, very well. If you haven't had a tetanus shot in the last 5 years, I would be getting a tetanus shot right away for that. So did you clean it out really well with like soap and water? Because you want to make sure that the wound is really, really clean. I'm sure they'll give you a tetanus shot tomorrow at the doctor's appointment. And then just keeping it covered, because with your feet, you do not want to get an infection in there. So just make sure that you keep that covered. You can put some Vaseline on it, as long as it's super, super clean. Put a layer of Vaseline on it, and then just put a Band-Aid over it. If you have like iodine, you could use some like povidone iodine to just cleanse it a little bit, just to make sure that there's no bacteria there, because like that can turn into a diabetic foot ulcer really, really easy if there is any sorts of bacteria there. And then just resting that foot for the day, because the more you walk on it, the more damage is going to be caused, and you're not going to be, possibly not going to be able to feel that. I'm not sure if you have neuropathy, like don't have feeling in your feet. So just making sure that you're really taking care of that foot right now, and not doing more damage to it because you don't feel that. But definitely make sure that you are keeping that clean, dry, and covered. Not a problem. I wish you the best of luck with that. Definitely, diabetic foot ulcers are definitely one of the worst to fix. So you want to make sure that you're taking care of it right away. Right away. They are super difficult to heal. Are you a roofer? Is that like something that could happen frequently? Because you might want to get a pair of shoes in that case, that nails can't go through. I know they do have like steel-toed shoes, but they do also have ones with a steel plate in the bottom. So if that's possibly something that could be happening frequently, that is always a choice too. So if you're just joining in and you have any wound care questions or any topics that you would like me to go over, please feel free to put them in the chat. Thanks so much for subscribing. you're just joining and you have any questions about wounds, wound topics, personal wound care, please feel free to put it in the chat and I will answer those questions for you. Sorry, I had my voice off. No, I'm not doing a wound dressing. I'm just doing computer work at the moment. It really depends on policy. So you can do it either way. Normally, me personally, I like to have absolutely everything ready. So prepared on the table, have your tray open, absolutely everything you need first. Have your little garbage next to you, and then you're removing the dressing, cleansing the wound, and going right into your actual dressing change. That's for the most part what most people do, because you don't want to leave that wound open to air longer than you have to, because just like there is bacteria always floating around, even dust particles, whatnot. So if we can minimize the amount of time that dressing's open, the better. So that's why we normally prepare it first. Especially depending on what type of area you're in and working in. Like, you have to keep things sterile, right? Especially at a hospital. So when you don't want to be opening up like bandages and whatnot after you just touch the wound, because then you're going to get it dirty, right? So you got to be cautious with that too. I always have everything that I need ready at my side and then start. I'm glad to see you back. Oh no. When you have a cut and you always, it doesn't matter if you can see it or if you don't see it, you want to wash that with soapy water. That's what I always suggest, is soapy water to wash out a wound. I don't like peroxide. Peroxide can damage good tissue. But if it has a bunch of like pebbles or something, like say a kid is running and a bunch of like sand, gravel, whatnot get into it, and you're washing it with soap and water and it's not coming out, sometimes you do need that peroxide. But with that said, it can slow down the healing process, it can impair the healing process, so we don't, that's like a last thing that we want to be using. But sometimes in that case, when there is the dirt like that, you do need to use the peroxide. Yeah, debriding a fresh wound would be painful. That's kind of when I would be using the peroxide more. Because the bubbling action of it will kind of lift it out, and then just keep flushing with water, saline, I'm not sure what type of debriding you're talking about, like Sharps debriding. Yeah, I'm just not sure what type of debriding you used. If anything, I would take like a saline soaked gauze and wipe over top of the wound to get that to get the dirt out. But yeah, in a fresh wound, debridement would be very painful. Okay, scraping the wound bed with gauze. Unfortunately, yeah, if that you did it perfectly. Just making sure that it is like soaked in saline, and then just going over top of it. But yeah, you got to get that out because it will get infected. Can get infected. I shouldn't say will get infected, but very good chances that it will get infected. You want to remove all those particles. The only thing you could have added was to pour peroxide on it in that case. Once again, something I don't like using, but sometimes we have to. Yeah, antimicrobials definitely shouldn't be used unless you start having signs and symptoms of infection, or if it's in a location that is at high risk. Okay, so a wound will actually heal faster without antimicrobials. If you're just doing your moisture management, that is key. Moisture management. But if it's in a location or it's at high risk of infection, then you can use an antimicrobial. But really, we don't want to be using them because there is tissue toxicity associated with antimicrobials. So even when you have a local infection on a wound, we're going to stop using it after 2 weeks once it has, as long as it's not having those signs of infection anymore, or we would have to move on to a different one, a different antimicrobial after 2 weeks. But they can cause unnecessary damage. So yeah, we don't like using them. Just moisture management. So any products like if you need to add moisture, if you just need to keep the same moisture, so using your meshes that just have like a paraffin cover over them. If you have higher exudate, then you would be using your like alginates just to and just with no antimicrobials in them, just to take care of the moisture management, because you want a just moist wound. That's how it heals properly. Yeah, definitely most people think more is better. Honestly, just cleaning it with gentle soap and water is more than enough. And then what I normally use, if it's just like a basic cut, just put some Vaseline over top of it to prevent like a bandage from sticking. Really, that's all that's needed. Because yeah, a lot of people like to use like polysporin or these antimicrobial creams that you can buy at the drugstores. Now, a lot of people actually have reaction to those and they don't even know. So it's such a mild reaction, but it causes like inflammation, redness around the wound. And so people just think it's like part of the process because it technically is, but sometimes it's actually a reaction to those products. They are very, very high rate of so many people like a light allergic reaction to them. So the antimicrobial creams are definitely not necessary, and just Vaseline works better. More is not always better in wound care, because even a lot of the nurses who I was like in the community with, a lot of times they would be like, yeah, but don't we need something more on this, and it's like, no, it will actually heal faster. Like, people have such a misconception, even nurses sometimes have that misconception. It will actually heal quicker without antimicrobials. Antimicrobials are only there when we're having complications. And also, bacteria, even on a wound, it will keep changing, so it can actually live with those antimicrobials. So we want to use them as least as we can. Just like taking antibiotics orally, using the topicals can do the same thing. So we don't want to misuse them. Now, when it comes into chronic wounds, so I mean, this is all with acute wounds, like just happened wounds, less than a month old. I'm wearing it now. Moisture is really important. Yep, you have to keep it. You have to keep it covered. So really, you depending on the type of wound, you just want to put some Vaseline on it for moisture management and keep it covered, and that will reduce scarring also. Because if you let it scab over, chances are you're going to have a scar there. If you just keep a nice moist wound base, it will heal over very nicely. But yeah, you definitely need to keep it covered. So I'm not a fan of letting a wound breathe, to be honest. Letting a wound breathe, it will cause a scab. So if you're getting a scab, then you're more likely to get a scar, more likely to get infection also. Yeah, I like to keep them covered. Even with skin tears, they have those acrylic tegaderms. So they have acrylic tegaderms, and you put them on, and they can stay on for 21 days. They create a wonderful moisture balance, and normally when you take it off, it's completely healed. Have I worked in a hospital as a wound care specialist? So I have worked in a wound clinic. Okay, so it's specifically just a wound clinic, doing for a wound care specialist and out in the community. So my time was kind of split up. I would go out into the community to do assessments on chronic wounds. So these are wounds that they cannot get healed. Nobody can get them healed. So I would go out, do my assessment, do my plan of care, and teach the nurses who are actually going to be doing the wound care. Go out with them a few times, make sure they're comfortable with the treatment plan, if they haven't done it before, especially with like back therapy, just making sure they have a good grasp. And then I will go out there normally about once a month, to see the patient, see how things are going. So, and really the same, like it kind of went hand in hand. It was the same company that actually had the wound clinic. So if patients could physically get out of their home and come to the clinic, I'd be doing the same thing there. So in a wound clinic, what happens is patients can just, they come in at their scheduled time, and then like we do have a bunch of nurses in there, and they just come into a room. You assess the wound, so your full wound assessment, and then me personally, I would be determining what we're going to be doing. What's the plan of care? So looking at the patient as a whole, not just the hole in the patient. That's my biggest thing, because you cannot heal a wound, especially chronic wounds, because that's what I deal with most is chronic wounds. You can't heal chronic wounds if you're not looking at the patient as a whole, because you need to know comorbidities. You need to know like what is going on with them, what could be impairing the healing process, and how to improve either their diet, adding, say, if it's a pressure ulcer, getting them and teaching them that they have to be moving every 2 hours, giving them, say, a ROHO cushion for them to sit on that redistributes pressure. You have to look at every aspect that could be impairing healing and fix it. That is how you fix a wound. And then just letting them know, like, it takes 1 full year for your skin to go back to normal after having a wound. So say you have a pressure sore on your bum. It's been healed for 1 week and they're like, okay, I don't need to move anymore. They have to be taught that it's like, no, you still have to move every 2 hours. You can't be sitting like that, because it's just going to be a reoccurrent issue. Because it does take that skin, it takes a year for it to go back to the way it was. So most of the time with pressure ulcers, it is reoccurrent issues because they just go back to their old ways. So it's really going over medication, comorbidities, their eating patterns. If they smoke, if somebody smokes, if we can just get them to reduce the amount they're smoking, it helps so much, because every time we have a smoke, it can take between 20 minutes to 2 hours, depending on how much they smoke, how long they've smoked, 20 minutes to 2 hours for their veins to relax again, because it tightens the veins, it constricts the veins and blood flow. So really, me personally, it's so much more than just wound care, my assessments. It's going over absolutely all the patient's information and asking all those questions. So I did even at the clinic. So once I was done with a patient, I would be having the other nurses see them on the regular basis if they had any questions or if there was any concerns, and they needed me in a room if a wound started getting bad. I would go in and check that out there too. What's my thought on Dopplers for an ABPI score and compression bandages? Absolutely love them. You have to 100% use a Doppler to get an APBI score. So we want to make sure that anytime somebody has venous issues in their legs, even swelling, even if they just have swelling, to use like compression stockings. So compression bandages are more for when we have an active wound. Now compression stockings are for life, okay? So the actual stockings before, and we can even use them with a wound. Sometimes they're just harder to get on. That's why we use the compression bandages to wrap the legs while we have an active wound. But definitely 100% we want to be getting an ABPI score to make sure that they can tolerate that compression and and get them in it immediately, because really that's the only way we're going to heal those venous leg ulcers. So are you able to do the ABPIs in the community? Because I know for us personally, it was only me and one other wound care specialist at our company who did that. It'd be pretty cool if all the nurses had access to that. It would move the process along so much quicker. Because I mean, I had to cover like 4 or 5 different towns because I was somebody that was doing the ABPI scores, so I was always just traveling a lot for that. Okay, so if it hasn't healed within 6 weeks, honestly, if somebody has a venous leg ulcer, so you're seeing that it's very irregular shape, they have swelling. If a leg is swelling, you're not going to heal it. If it's going smaller, bigger one day, smaller the next day, it's not going to heal because it keeps stretching that wound. You're not allowing it to heal. Normally we try, if it's a venous issue on the leg, it's immediate. The quicker, because the longer we're leaving a wound, we can get biofilms, infections. We want to heal them as quickly as possible and get it done immediately. And compressions, so important. I like to get somebody in a compression right away, especially if it's a venous leg ulcer. So making sure that we're doing the ABPI so their leg can tolerate the compression and that there's no arterial disease in there. But getting on a compression bandage immediately is how we're going to heal that super fast, and it really prevents long-term complications. Okay, so the difference between a venous ulcer and an arterial ulcer. I wonder if I can, I don't know if I can screen share this. I don't think I can. Okay, so a venous ulcer is going to be very irregular, okay? So the shape is not a circle, okay? Arterial, it looks like it's been punched out. So it's a circle, and it looks like it's been like perfectly punched out of the skin. Arterial will also most of the time not have leg hair, okay? Their leg hair, they will not have any. Okay, so their legs with venous disease, the fluid pools. So when you think of your veins bring the blood back up to the heart. Okay, so if our veins aren't working, they're not bringing the blood back up to the heart, the fluid is going to pool in our legs. Okay, so then that's when we start seeing our legs weep. They get very large, and we have these irregular venous leg ulcers. They are not, they're very misshapen, okay? They're not symmetrical at all for venous leg ulcers. And then once again with our arterial ulcers, they're very punch-like, so they look like a circle. They look like they've been punched out. And most of the time, no leg hair. Now, sometimes we can have a mix of the two. That's when our ABPIs come in handy, and we can tell if there's a mix, if there's arterial disease going on. Nowadays, it seems like there's so much of a mix. And if there is a mix, we need to really get them to a vascular surgeon, and then they can determine how much compression we can be putting on them. Because even like a 2B grip, just a light compression, most of the time that's what ends up happening, just a very, very light compression to move some of the fluid to heal these wounds. Why do we do a Doppler for an ABPI? So an ABPI, can the sounds help you assess? Yes, 100%. You have to know your sounds when you do an APBI, because yes, you get your numbers, but the sounds also will tell you if it's a healthy leg. You hear the sounds, and if it's like a one sound or a triple sound or just a double sound, it really you gotta have the Doppler to be doing an ABPI properly when compressing the legs, because you also have to hear when the heartbeat is stopping and starting to get those numbers. If I can just know if I hear it or not. Okay, then I'm not 100% sure, because APBIs are done very kind of specific across the board. And then the Doppler, it allows you to hear it out loud, right? The different sounds, because you're listening to that artery to hear when it's stopping. So you really, like, I've never heard of it done without a Doppler before. That's very interesting. Yes, okay. So there are three specific sounds. You have monophasic, biphasic, and triphasic sounds. So your triphasic, it's literally, it's hearing the heart. So you're listening to the artery and you're listening to the sounds of the heart. So your triphasic is normal. And then like just listening to it and then having the numbers, it normally correlates. So you do have a chart, and it tells you whether you're within normal range and what type of compression that can actually be handled by the leg, because you can't just put somebody in compressions. You have to have your ABPI number to ensure they can tolerate the compression, because if you have arterial disease and you're putting compressions on them, so arterial, your blood is flowing to the limb. If you're already having problems with blood flowing to the limb and you're now compressing it, so the blood now can't flow there, your legs can go necrotic, and your toes can go necrotic quite quickly. If they're not getting blood, the toes are going to die, right? So yeah, that's a bit more like complicated than what I could explain on a live. But definitely ABPIs are something that has to be done. Now, I know here not every nurse can do them, and so you have to be specially trained for that. Like it's not something I specifically learned in nursing school. When I went on to expand in to be a wound care specialist, that's when I learned about APPIs. That's when I started doing them. But once again, you can learn as a community nurse. You learn a lot of these skills by being taught by other nurses. Because it's something you're so alone in a community setting that people need to know these things. So sometimes they're allowed to do this. But an ABPI really is just saying if you can put compressions on a leg and how much they can tolerate. That's really what it is. No. So, technically, if that's what I wanted to get into, 100% I could work in a hospital setting, emergency trauma. I have chose personally not to do so. I have a family. I need regular working hours. So really, as a wound care specialist, Monday to Friday, 8 or 9 till 4, like it's really I get to schedule my own hours. So yeah, I've never really had interest in going into a hospital and working all those different hours. But with that said, once we have somebody on service, I have gone out, like if somebody's having complications or if a new wound has arisen, like once they're on our service, they can call us 24/7. So not me personally, but they call the company, and then the nurses on call can go out. I have done that multiple times, gone out to situations, but most of the time they're not emergencies because they have to give us time to get there, right? So if that were the case, they would go into the hospital to do so. But yeah, it's just my choice and preference. Okay, so for a moist wound environment, it is optimal for wound healing. So you don't want to have a wound too wet. You don't want to have it too moist. You just want to have a just moist wound. This is like the perfect environment. So if you have a really dry wound, you would say add like a wound gel to it. Normally you only have to do this once or twice to get that moist wound environment, and then just using I'm sure you've seen those patches. They have the little holes in them. It's like a paraffin patch that you just put over a wound. That way it just lets any exudate through. It keeps it moist, keeps the bandage from sticking, because really what we want to do is keep bandages from sticking and causing damage to the wound when we go to take them off. If a wound has a lot of exudate, we want to be controlling that too, because if we have maceration around the outside of a wound, it allows the wound to get bigger. So we want to make sure that we're absorbing any excess moisture into that cover dressing. When a wound develops a scab, once dried, it usually pink and healthy underneath. So, okay, so it's difficult because we have always understood as scabs, it protects the wound, right? But with that said, we now know if we keep a nice, just moist wound, keep it covered, it has less chances of getting infected. It has less chances of scarring. So, and then for later on, so it takes about a year to have our tissues go back to normal, as they were before. So we want to make sure that we're not getting a scab, because it will actually heal and have stronger skin that way. It is confusing because a scab, it'll cause scarring. Really, that's what we're trying to prevent, and just have that nice wound environment. It will heal quicker. Okay, scabs. People like to pick at scabs, right? It causes scarring. It's best practice to keep a wound moist, even with our oh god, I went blank. Even like our skin tears. So we can use a Tegaderm. They have like Tegaderm acrylics that have it's completely see-through, but it has a little absorbing pad in there, and they can be left on for 21 days. I absolutely love them for skin tears because you can see through it. For one, you can see how a wound is doing, and for two, you leave it on for 21 days, you take it off, and it's completely healed. No, stronger skin is a good thing, okay? So, if we're having a nice wound base, nice and moist wound base, and letting it heal that way, for one, it will heal quicker, and for two, it will be stronger skin, so reoccurrence of another wound won't happen. My dog's decided to join me. Somewhere before you were talking about Vaseline. Yes. So, he's fine. I personally like Vaseline, especially for just like at home wounds. I always suggest Vaseline because a lot of people like to use these antimicrobial, antibiotic creams. They're, for one, unnecessary because you're just going to cleanse a wound with soap and water at home. And for two, most of the time they cause irritation. People have a slight allergic reaction. I think it's like 60% of people have a slight allergic reaction to, like, say, a polysporin. And so they're seeing like redness around the wound, and it's not the actual wound, it's the polysporin that is actually causing this irritation. So what kind of wounds do I recommend using Vaseline on? I don't like, if you're talking about polysporin, I don't like using them at all personally. There's a lot better antimicrobials that we can use. But for Vaseline, so these are our acute wounds. When we're talking about our acute wounds, like between less than 3 weeks old wound, that's what I would use Vaseline on. No sign of infection. I wouldn't want to be using it on our chronic wounds. But for Vaseline, we're going to be using it on our acute wounds that have an awesome chance of healing. we're going to be using Vaseline on that. It also prevents the bandage from sticking, so when we pull off the bandage, we're not causing any damage to the wound, but it's keeping just a nice wound, moist wound. So Vaseline doesn't actually absorb into the skin. It kind of just stays there, creating a moist environment on top of the wound. So we use our Vaseline for acute wounds. So the spit on wounds, not a healthy practice. Yeah, not a healthy practice. I have heard that it kind of puts a layer over it to stop it from bleeding. But yeah, you have so much bacteria in your mouth. Not a good option. Just like putting like soap, like a mild soap and water, washing it up really good, and holding pressure to it. Holding pressure for 5-10 minutes, whatever you need to get that bleeding to stop. But I have heard of that. Not a good practice whatsoever for anybody to be doing that. That is a good one though. Not a good practice. Really, for acute wounds, just cleansing them with soap and water. That's all you need. No peroxide. Peroxide is such a toxin to our tissues, and just it honestly prevents healing. It destroys good tissues. The only time we use it is for when we need to get like stones and dirt out of a wound that isn't being cleaned out by soap and water. Yeah. Yeah, really, with wounds, we just want to give them the best possible chance of healing and not reopening. That's our main goal, is to get it to close without infection, without complication, and prevent it from reopening in the future. Are you talking about the peri wound or the actual wound itself? That would be like inflammation. So inflammation is really not good either. It's not good for wound healing. Sometimes, like if there is swelling, okay, because that is a sign of infection, right? So like using your nerds and stonies, that's like redness, swelling, edema. That's a sign of infection. Okay. It completely depends on how bad it is, because is it an acute wound? Is it a chronic wound? Because inflammation is a normal stage of wound healing, But if it's getting stuck in that stage, then that's where we go into a chronic wound. And now chronic wounds, sometimes we get biofilms on our chronic wounds and they get stuck in a stage of wound healing. So that inflammatory stage, it could be stuck in, and sometimes that's a good indication of a biofilm on that wound. Biofilms are super, I wouldn't say super difficult to get rid of, but I mean, they grow back within a day. Like mature biofilms, if just left, and you can't see them. Like, you can't see biofilms. So, I mean, if it's getting stuck in that inflammatory stage, there is an issue there. So either a deeper infection going on that's just not being seen, or a biofilm. Stage 4 large chronic diabetic foot ulcer. Wound bed is hypergranulated. Peri-wound dry, callus. Client unable to have compression. Also, okay, so the main thing with diabetic foot ulcers that have calluses, if there is a dry callus around the wound, it's got to be removed. It's got to go down. Now, you got to be super cautious. I don't know if you specifically are allowed to do sharp debridement, but definitely that callus has to be removed. That wound, oh Drake, it absolutely will not heal if that callus isn't removed. So that would be my main thing, is removing that callus down to nice healthy tissue, just where it's soft. Like, you're not going to go down to bleeding tissue whatsoever, not even close to that with a diabetic ulcer. But you have to treat that dry callus, getting rid of that dry callus. Okay. Was it the mee-salt? Normally we're using that to take out moisture, right? So, yeah, the inidine would work great. I've never seen the other one. I don't know what this is. Let's look it up really quick. Sometimes in different countries, like, we don't have all the same products, but it's really the same thing as something we have here. Okay, so it's just to absorb moderate to high amounts of exudate. Okay. Okay, so with the removing of the callus, yeah, we want to make sure that is removed, because really that's the only way. If there's a callus there, and I mean, they build up quite quickly. The other thing that I can suggest is, so for the compressions, the client can't have compressions. Would, like, not at all, like, not even like tubing grip. We couldn't even use a tubing grip. That's a possibility. Also, offloading shoes with diabetic foot ulcers. If the only other thing that we can do is use an offloading shoe. So there is different types of shoes. I mean, you can even get them on Amazon, but you might want to talk to like a medical supply store, because they would be able to help the patient be fitted and see which ones they exactly need, because depending on where the sore is, so if it's at the front of the foot, it'll offload the front of the foot. If it's the back of the foot, it'll offload the back of the foot. So offloading shoes really help with diabetic foot ulcers too. Yes, I seen that, an absorbing pad. So yeah, the Yeah, so I mean it's perfect wound care, but you have to think like wound care is not just about that wound. It's looking at the patient as a whole. So what can we change in the whole scenario, in the whole patient to fix that wound? So making sure that his sugars are he's not having spikes, okay? So they have to be very controlled. We have to control sugars when we have a wound. If they're not being controlled, that will impair wound healing. We need to optimize nutrition, so increasing protein, making sure they're having just a small protein with each meal 3 times a day. If they're a smoker, reducing smoking. Because it's on the foot, diabetic foot, an offloading shoe. Just looking at the patient as a whole. What can we do to optimize healing? You always have to think of that. Okay, so that's like the wound healing drinks. So those are great. It gives them the nutrition that they need. But also, with that said, if we're not fixing outside causes, if we're not looking at the patient as a whole, not taking pressure, because with diabetic foot ulcers, we have to remove that pressure. They can't have pressure on that. So it's super, super important to remove that pressure, or it's just going to continue to get larger. A lot of times people with diabetes, they get neuropathy. They can't feel their feet. They have no idea that that hurts and how much it actually hurts. Yes, unfortunately, a smoker. Okay, so honestly, yes, we can educate as much as we want. Most of the time, people will not stop smoking because that's more important than their wound. They can't feel their wound most of the time, so they will not stop smoking. But if you can just get them to minimize the amount that they're smoking, so maybe go for longer stretches, just kind of explain to them that when we have a smoke, it constricts our blood vessels and can constrict it up to 2 hours, depending on how long they've smoked for, how many smokes they're having. If we can just get them to reduce the amount of smokes that they have in a day, because somebody's not for the most part, not going to quit, but just educating them, right? That's all that our job is to do, is educating and optimize wound healing. An offloading shoe, though, will probably really, really help. So normally, for the most part, it's just, you can get just one shoe. It's Velcro over, and it offloads wherever you need it on the foot. Okay, so with arterial ulcers, I Odosorb powder. So could be great, depends on the wound. I've used it myself. If you're looking to debride the wound, like get that sloughy material out of there, it will act as a debrider. So a lot of times arterials have slough on the wound. So I'm assuming it's a good choice as long as it's a sloughy wound. I wouldn't really use it on a clean wound base, because I mean, if it has a clean wound base, then it should heal. Okay, so normally it can be from either here. Okay, so we'll start with venous leg ulcers, because when we have blood just pooling in the area, that's how we start with our ulcers. So sometimes just a little budge to the skin, the slightest little cut, can all of a sudden grow into these huge ulcers. With that said, with venous leg ulcers, sometimes our legs get so swollen because they're not being properly cared for. So wearing compressions, if they can't wear compressions, having a diuretic medication to remove that fluid. Yeah, it can start, it just, like micro little tears in the skin just from letting that fluid seep out will cause a sore 100%. But sometimes there is outside factors too to it. So if somebody has venous disease and they have trauma to their leg, it will cause a venous leg ulcer. So it's kind of a mix between a traumatic that has turned into a venous leg ulcer. Now with arterial ulcers, these are so difficult because, yeah, 100% but with this said, like a micro tear in the skin. When you have arterial disease, it is so important to get somebody into a vascular surgeon immediately to see if something can be done, because really it's going to be a constant problem. Arterial ulcers rarely heal. You can, depending on how bad, if you're getting to the point of getting arterial ulcers, it's bad. They need to be seen a vascular surgeon. Okay, so biofilms on a wound bed. What is your question about that? Because biofilms are a crazy little thing. It's like a little colony that is just encapsulated on top of a wound, and it really doesn't allow, like this layer, it doesn't allow like antimicrobial or things to work on it. So you have to disrupt that biofilm. Normally it's done by debridement, frequent debridement, and really cleaning the wound more on the rough side, so using the gauze, and you can almost feel a biofilm. Like you can't really see it unless it has like just been left and not taken care of. Then you can start seeing a biofilm. But most of the time it's that slimy. So when you go to use a gauze on the wound and you go to wipe it, it's slimy. It feels slimy. So that's your biofilm. And I mean, you would just want to be like really like keep wiping and wiping, disrupting that, and then using antimicrobials on top of it. And now antimicrobials to kill bacteria. We don't just want to inhibit them, we want to kill them. So our iodine, our silver products mostly used. I am going to be having a video. Let's see here. I don't know what day specifically it's coming out. And it is specific to biofilms. September 19th, the video will be coming out on biofilms, how to recognize it, how to treat it. It has all the information you need to know about biofilms, and it's scheduled for September 19th to come out. So that is Monday it's scheduled. Okay, so compressions, anytime you have compressions, so easiest way to think of venous, so your veins are bringing your fluid back up to your heart. They have little valves in them, okay? And when you're having issues with your venous system, these valves stay open and the fluid pools at your feet. So it needs help. It needs to be compressed. And now compression stockings, they are gradual compressions, so it'll help push that fluid back up. That's venous. Now arterial disease, we do not want to be using compressions. And that's why our ABPIs are so important, to know if we can compress a leg. Because if we have arterial disease in there, we do not want to be compressing a leg, because our arterial, it flows from our heart to our feet. If we compress that, a system that's already broken, so we're having arterial disease, the blood flow is not flowing properly to our legs, start compressing it, it's going to act like a tourniquet, right? and the blood flow is not going to be able to get to those toes, and you'll end up with necrotic toes, and they'll have to get them amputated. So that's why it's so important. Anytime we have an ulcer on the legs, an ABPI should be done immediately within the first 2 weeks of appointments. I know that, like, that's our policy here. We need to be seen if we can put them in compressions, because for one, it'll heal so much quicker. We don't want to be giving it time to get infections, whatnot. Okay. Yes. So giving an antibiotic. What's your thoughts on it? Okay. So first off, with wounds, I even find here that sometimes I have had to educate doctors because they're not fully assessing a wound properly. And I mean, GPs, they have so much knowledge of just general across the board, okay? Amazing. They're amazing. But when it comes to specifically wounds, sometimes I have had to talk to them. Like, okay, look, I'm using my nerds and stonies. So, and like, because we send faxes back and forth. That's how we deal with the doctors. With our wounds. So sometimes I just have to give them all the information and almost tell them what I need, okay? With that said, nerds and stonies, if you don't know that, definitely look up my video on that, because that will tell you the difference if you have a local infection, which just needs to be treated topically, or if you have a deep spreading infection, which is your stonies. And it'll teach you everything you need to know on that. And then I would just tell the doctor, okay, look, we have a local infection. We just need an order to be able to use an antimicrobial on the wound. I believe this is more than enough at this point. We don't need an antibiotic because it's just showing signs and symptoms of a local infection. And I believe if we use such product, either iodine, silver, chlorhexidine, whatever you think would work better on that wound, ask for it. Honestly, that's what I do. Now, so sometimes we we have a deep spreading infection. You can say that it has signs and symptoms of a deep spreading infection. The patient is in need of an antibiotic. So just really advocating. So even here, sometimes wound swabs are harder to get. So a lot of times, like, I've really advocated, you have to advocate for these things. Even if they want to start them on an antibiotic, like, hey, do you think we could just do a swab of the wound and make sure that this is an appropriate medication? Or, hey, do you mind if we swab the wound before we start this? Could we get an order for that? You must advocate, because you know the steps that need to happen to ensure that we are getting the right, like, antimicrobials, the right antibiotics. We need to take these steps, and you need to advocate, because, like, wounds, they're so complicated. They truly are. There's just so much involving with them. And yeah, if we can swab a wound, it's so simple to swab a wound, but sometimes it's just asking for it. Okay, so normally when somebody has an arterial ulcer, we want to get them, like, the damage is done, okay? So they really, if it's gotten to that point, they need to see a vascular surgeon, okay? Arterial, if you suspect somebody of arterial disease, they need to get to a vascular surgeon. They actually strip the veins to get the blood flowing back to that area. Yeah, the nerds and stonies. A lot of people aren't aware of that, but it's just a simple, like, it just gives you. It's very, very simple to use the chart, and it literally just tells you, okay, do I have a local infection? Do I have a deep spreading infection? You have to have 3 on the chart on like each side, or say you have like 3 on one side. Like you have to have 3. Even if you have like 2, I normally don't treat it. It just depends on the wound, but you want 3 on the chart to start treating it for infection. You know what? Here's the thing. I never learned. Most of the stuff I learned was not in nursing. Okay, and like our nursing course, it had tops a cut like 1 or 2 classes on wound care itself. It was more like how to stage a pressure ulcer, how to stage a burn, like not getting into the very specifics of wound care. So when I specialized, when I actually went to school to be a wound care specialist, that's when I started learning all of this. So that's why I'm sharing it, because nurses, like if you work in the community setting, I'm sure most of your time is spent on wound care. I know for here in the community setting, majority of the time is wound care, a little bit of the time is on palliative care. I'm not sure what it is in Australia, or if it's separate nurses who do what not. But like wound care is such a big thing, and that's why I want to share my knowledge and put it out there for everyone, because if you're just like throwing products at it, like it's very difficult to get a wound to clean or a wound to heal. And I didn't even realize before like going, like I was a community nurse for I believe 2 years before I went to be a wound care specialist. And I always struggled with what I should be putting on a wound. But like now it's just so second nature to me, like how to assess a wound. But yeah, that's just why I'm trying to share all the knowledge I have, because if this is something you're doing day in and day out, it's hard to determine, and you have to be looking at a person as a whole and treat all these outside factors before you'll ever get a wound to heal. Yeah, so with burns, and I've been working on all these videos. So like I do have all my product videos that I've done, but now I'm working on all like educational videos. And even with that, like, yeah, so you're saying like so many products to learn. Know the basics. So you have your meshes, okay, that have the little holes in it allowing exudate to go through. And then you have like your alginates, really. And once you know what you need to do for moisture balance, you just use the product. So okay, and then you have your moisture balance. Moisture balance is always so important. But then using your nerds and stonies. Do I have a local infection? If you have a local infection, just add an antimicrobial. So they all come in plain, and then they all come with your antimicrobials. So like the meshes, it comes in your antimicrobials, your chlorhexidine, your iodine, your silvers. Which one do you want to use? Which one do you think is most appropriate for that wound? And then even your alginates, like it comes in your plain, it comes in your antimicrobials. So really, it's not like once you know, like, okay, I want to use a mesh to just keep the moisture that we have there, prevent sticking. Okay, do I need an antimicrobial with that, or am I using one that's plain? It becomes so much simpler when you look at it like that, because even for me, for products, some countries have different products than we have here, but they're all the same. When it comes down to it, okay, it's a mesh, it's an alginate, it's this, it's that. It has this antimicrobial. It's still the same thing that we're using here. It just has different names, really. I think even if you know just a few products, you need to what you need to know is the product itself rather than the name. Okay? So when it comes down to it, if you know your antimicrobials, so your iodine, your chlorhexidine, your silvers. Okay? You know those. And then just know, okay, do we need a mesh? Do we need something more absorbent? Like, what do we need to put on there? What are we trying to achieve with our moisture balance? Okay? And then really, you know all your products right through that. Like, sometimes like our Acticoat Flex, yeah, they have, like, you can't use, you have to use sterile water with it. You can't use saline. It's just because it has like nanoparticles of silver. So you have to have some product knowledge of the products that you're using all the time. Depending on like where you're working, sometimes like in hospital setting, the doctors are writing these orders. So they're not really using like best practice. More in the community setting, that's when they're like, hey, like, you just use best practice wound care. Okay, so that's when you need a lot more knowledge of wound care, is when you're making these decisions. That's an interesting one. So, Inadine with Mepilex with border. One second here. Mepilex isn't something that we use frequent here. But we have something similar, like very similar. Okay, so does the Mepilex have like silver in it? Like it just depends. Like, you're not supposed to put two antimicrobials together, but I don't see why you couldn't use Oh, okay. So that's the reason, because Mepilex, okay, is an absorbent dressing. And you're putting on something to keep a wound moist. So normally with like the iodine patch, I normally just use like a gauze dressing, because the Mepilex is absorbent. It's going to pull moisture out of that, right? So you're trying to keep a just moist wound with that, and you're taking out any moisture into the Mepilex. Now, I mean, if you had a moderate wound, exudating wound, that you could technically use it, because you're allowing the exudate to flow through the Inadine product and go into the Mepilex. Yeah, because it's going to, so I wouldn't say it's 100% wrong though. Like, if it's all about moisture balance, right? So yeah, you don't want to be just absorbing all that. Like, normally with a mesh, I'm only going to use a gauze dressing. But with that said, if we need a waterproof bandage. I don't know if the Mepilex, I don't think it is waterproof. More of your like your Alleven Life. Those are those are waterproof. It's a hard one to say. Normally I just use a gauze dressing. Gauze and tape. Yeah, if I'm using just a light gauze, because I'm if we're using like Inidine, I'm not expecting to have very much exudate coming from the wound to begin with. Tegaderms, most of the time we're using those for like no moisture. I don't personally use a Tegaderm over top. I'll use a Tegaderm over top if somebody wants to have a shower and we're covering a dressing, just as like a waterproof film over top. I do that. Tegaderm, the acrylic one, I use for skin tears. Because you just clean up the skin tear. If you still have a flap of skin there, pull it back over, and you're literally just leaving it on for 21 days, and it should be healed by the time you pull it off. Honestly, for the most part, with any of my meshes, I use just a gauze dressing over top. Gauze, sometimes, like if somebody's skin is really fragile, I will use cling and then tape. How do you keep it stuck there? Okay, so like a gauze, yeah, like a gauze. When I say a gauze dressing, you can literally use just a sterile gauze and tape it on. So you put like it's up to you. It depends on how much exudate you have. So just like sometimes you just need like a sterile gauze, or you can go to like your higher absorbent, like your Mesorb. How do you keep it stuck there? You can just put a little bit of tape or cling. If you're using cling, I always like just tape down a little bit on the inside. This is for people with really fragile skin. I just like kind of tack it, and then I will use a cling and then tape that on. Me Poor Pro. We don't have, let's see. Not a product we have here. Okay. I can see that. So it's an absorbent, breathable dressing. So why I like the Tegaderm acrylic is because you can see through it. You can see the wound healing, and it can stay on for 21 days. So it really it reduces the amount of times we have to be there to see a patient, and we can see right through it. We can see the healing process, see if anything's going on, and also reduces how many products we're using, cost, because here in Canada, I'm not sure about there. I honestly don't know. But like everything's covered for healthcare, right? So like all these products are covered for patients. But we have to be very cautious with how many products we're using. So if we can minimize the amount of products, that's what we need to do. Well, all right, guys. I have already stayed on for about 45 minutes extra here. So next week, I think I'm going to come on a little bit later, so about like 10 till 12. So I will catch you guys then. We'll give you a lesson on Aussie wound care products. Yeah, well, I mean, it just takes me a second to look it up for just a second here. Normally, it's quite quick because, once again, once you know what a product is, all I have to see is, like, what it looks like and does it have an antimicrobial to it, and I can tell you, like, the functions, like, what it's used for, what not. So it's pretty like simple because I can interchange products. It's just knowing the names of all of what you use there can be a little bit difficult. So yes. So once again, I will catch you guys next Wednesday. I come on Wednesdays, and next week I'll be here from 10 till noon. So 10 till noon. That's like right now. That's like right now time. Because I've stayed on till noon my time. You guys came on about 10:20 a.m. my time. So I don't know what time it is there right now for you guys. But it seems like the majority of people who hop on come on about 10 o'clock. And like I said, right now, it's 11:45 a.m. here. So, you guys hopped on here. It is not a problem. I love helping out in any way I can. Oh, it's 11:45 there. Okay, so it's a 12-hour difference. So, yeah, I'll be hopping on about 10 p.m. your time then. Yeah, and going till midnight. So, have a good sleep, and hope to see you guys next Wednesday. Bye, guys.